My honor to be here to share with you some information about spine imaging. What I like about giving this talk to a very broad audience is that you may read spine MRI if you're a musculoskeletal radiologist like myself, if you're a neuroradiologist, or very commonly as a general radiologist. So I think this talk has very broad appeal, and really the reason for giving it was I was tired of people saying that spine MRI is useless. Certainly there's a lot of challenges with doing spine imaging, and we'll talk about those. But at a place where I work, where we're very close with the orthopedic surgeons and the spine surgeons, we very frequently add value to our interpretations with spine imaging. And so that's what we're going to talk about for the next 30 minutes. So why do we image? Well, a key role for MRI is the detection of underlying systemic disease. So MRI is exquisite at not only the depiction of the pathoanatomy, which we'll talk about, but for detecting lesions such as tumors, infections, spinal arthropathy, and fracture. So MRI is really great at seeing those types of lesions, especially when they have lots of water around them on our fluid sensitive sequences. However, the issue is the systemic disease is not that common. So looking at different series, we see that there's only a few percentage of times where we're going to have these so-called sinister type pathologies, but they are very critical to make that diagnosis. By and large, we're imaging for things like pain. So most of the times we're imaging for pain. So our challenge is that there's this low prevalence of systemic disease, which MRI is exquisite for. So most of the findings we're going to see are what's called degenerative, and we'll talk about what that term means. Imaging is a test that relies on the imaging acquisition, but also on the observer or the interpreter. It's characterized by certain performance characteristics such as sensitivity and specificity. So specificity is negative in health, and we have a specificity issue with MR imaging of the spine because there are many degenerative findings in non-symptomatic patients. So you sitting in the audience, if I was to MRI all of your spines, even those of you who don't have pain, will have some of these features we talk about. In general, they're related to age. So this is kind of an age or maturational process. And this is in excess of the disease prevalence, so let's say persistent back pain or persistent leg pain. We also have a sensitivity problem because we tend to image MRI systems you're laying down supine in a non-loaded position, often non-painful. MRI is relatively long examination acquisition compared to others, so we want to make the person comfortable, so we're not loading them. So we may not see some lesions, and we'll talk about how combining the MRI with upright radiography can help in that regard. And then ideally what we'd like from imaging is, can we help predict the clinical course? Can I show you this big disc herniation and tell you it's going to take so long to get better, or these are the symptoms, or a response to therapy? Unfortunately, the answer to those questions are by and large no, but imaging is still very useful within the clinical context. So on this busy slide, this is a slide showing a number of studies that looked at non-symptomatic people, so people without pain. And I just point to a couple of different columns that if we look at things such as disc degeneration, we see that this can occur in a substantial proportion of patients depending on which modality you use and which population you study. And also the same thing with disc herniations in general, if we use that broad term herniation. So it can be important to subtype the herniation, and we'll talk about that. So let's talk a little bit about low back pain. So this is that dull aching pain centered in the lumbar spine, can radiate into the buttocks or the thigh. Usually does not go beyond the knee, but it can go toward the knee. So sometimes it is confused with sciatic pain, but that's low back pain. And so that pain is really difficult and elusive to determine the cause because there's so many structures around the spine that can have that referral pattern. So if we're going to look at our imaging tests, we need to have a reference standard. There's not great reference standards, but for a person like myself who does spine injections and works with people who do spine injections, we can use spine injections as our reference standard, whether it's removing the pain or provoking the pain. And so if we use spine injections as our reference standard, about 40, for people who come in with this low back pain syndrome, about 30 to 40% will be disc. Up to 15% will be the facet joints, or what is also known as the zygapophyseal or Z joints in the pain management circles, and then the sacroiliac joint in up to about 20%. So when we look at our disc imaging, we can apply the Fearman classification. We don't do this formally. It's mostly for research studies, but Christian Fearman had developed this scale, and if you go from the top, from A all the way down to the bottom to E, we see A is a nice bright central disc. The water binding capacity of the central nucleus is present. B has this little cleft. So A and B are normal discs, and if you put a needle in that disc, you don't get pain if you're using discography. So those are discs that we can say are completely normal by MR imaging. If you go to the bottom one where you see the disc space is very collapsed and there's a lot of osteophytic ridging, that is an end-stage disc. So for those of us who do discography, who put a needle in that disc, it's usually not painful either. At that time, it's gone on to its end stage. So the ones that are dilemmas are what our surgeons sometimes call so-called dark disc or black disc, which is a C and D, where you've lost some of the nuclear annular distinction, you have some disc degeneration or so-called disc desiccation. Pathologically, it's not really desiccation, so we prefer the term degeneration, although degeneration is not a perfect term either. So now, as I mentioned, with that degenerative disc disease, those features are not painful in and of themselves. They could potentially be pain generators, and we're going to talk about what other findings will help you increase the likelihood that they're painful. But simply saying that you have a degenerated disc, and this gets along with patient education, and in the U.S. It's a big deal now, and many patients are contacting radiologists to also explain their exams. But typically, it's the surgeon or the pain management doctor. They read a report. Dr. Carrino said, "I have degenerated disc. Isn't that my pain?" No, it just means mostly that you're getting old, or that your disc has maybe potentially been injured, or you have a genetic predisposition to getting this. So by virtue of a radiologist saying degenerative disc disease, this is not a diagnosis of back pain. So we need to pull out other other findings. Now, when we have disc pain, there's this concept that was started in the 70s of internal disc derangement. So it's a specific condition that's different from simply our degenerated disc disease. So you have degradation of the milieu inside of the disc. You develop these fissures that are often contained. It's related to a so-called annular fissure or annular tear, and it is also related to the end plate. So the end plate of the disc is the biochemical and nutritional interface between the disc and the body. That's where the vessels come in, that's where the nutrition comes in, and you can get fatigue failure of those end plates. And this occurs in certain animal models naturally, such as in sand rats, but it's also experimentally shown that this is part of this internal disc derangement. And this will get to the two findings that we talk about when we want to talk about identifying annular fissures or tears, and also these end plate changes. So it's been shown through not only with animal investigations, but other investigations, that there's differences in the biophysical and biochemical components that occur inside the disc, and this can correlate with pain, such as done on a disco CT or an area where you're showing an annular fissure or annular tear. So let's translate that to MRI. So the two of the MRI findings that then become important for you to identify in somebody who has pain is a hyperintense zone and these so-called modic changes, or these end plate lesions. So what is the HIZ? So HIZ is not part of the standard terminology, so there's a nomenclature that's endorsed by many radiology societies and also many clinical societies. HIZ was the term used originally to describe it for hyperintense zone. In our reports, we call them annular fissures. So what it is a bright T2 signal in the annulus. So normally the annulus should be dark, right? It's annular, it's a fibrous tissue, it should be dark on all pulse sequences. But here we have a bright signal that's near or equal to fluid. If you do a T1 weighted image, it's inconspicuous unless you give contrast material. Now normally we don't give contrast material for routine back pain, and so this finding is not always observed, but the annular fissures that tend to enhance is because they have granulation tissue. So this granulation tissue is a healing or reparative phenomena that brings in not only blood vessels but pain fibers. So these other pain fibers are felt to mediate the pain in people with these HIZs or annular fissures or annular tears. So again, the annular fissure is the preferred term, so I'll use that for the rest of the talk. So in the original study, this was found to have a pretty good sensitivity, so modest sensitivity and fairly high specificity. So put its positive predictive value in the mid-80s, which is actually pretty good for many of the imaging findings we have. And this has been, again, looked at by a number of other investigators. So one other way to express this. So this was identified in the early 90s. And so since then there have been a number of other studies that have used the likelihood ratio, so looking at the likelihood pre and post test, and anywhere likelihood ratios up to close to 10. So this finding is felt in a person that has axial back pain, because you can see it in non-symptomatic people. But if you're coming in for back pain, this has a high predictive value that motion segment is your painful motion segment. So beyond the annular fissure, or HIZ, we can think about the modic lesions. So with the modic lesions, there are 3 different types. They have edema-like signal, a fat-like signal, and then sclerosis. So they do reflect a continuum or spectrum. So when populations are followed, and this has been done with MRI following people's back MRIs over about a decade, 10 years or so, you can go from edema to fat to sclerosis. And so if we think of that process as edema being kind of reactive, and so edema is one of our reactive features that we see in bone. When bone gets irritated, it tells us it's irritated by seeing the edema. If they biopsy those end plates, there is some inflammation that can be seen there. Sometimes the bacteria is implicated. So recently the P. acnes bacteria has been implicated in degenerative disc disease, but probably not panning out because we can find P. acnes in a lot of different areas in our body. After the edema part resolves, you get a reparative phase. And so you deplete the myeloid elements in the bone, and now it gets replaced with fat. And then toward the end, you get sclerosis, just like you get at the end stage of any other joint when you look at an end stage degenerated joint. So what do these look like on MRI? So here's a classic one. So you have low T1, bright T2. We're basically following fluid signal. It's hemispherical, it's abutting the end plate, the disc is degenerated, meaning the disc signal is dark, although sometimes the disc can be a little bright because of either a gas in there. But this is our classic degenerative end plate changes. You can call them modic changes, you can call them end plate reactive changes. But this is associated with degenerative disc disease, and when it's this size, typically greater than 50% of the AP dimension and 1/3 of the craniocaudal dimension, these are associated with pain in several different studies using discography. So that's our modic 1. So modic 2 is, again, end plate, typically hemispherical. This time it's fat signal. And so if you look at it, you say, well, the marrow next to it is fat. Why is this brighter? Remember that the marrow, your hematopoietic marrow, your red marrow, your blood-producing marrow is still in your axial skeleton as an adult. So the fat next to it is about up to 80% fat, 40 to 80% depending on your age and your hematopoietic reserve. This is closer to 100% fat. So that's why it's similar to the subcutaneous or retroperitoneal fat. And so type 2 is kind of that second stage after the edema resolves, and some people feel the edema is related to an instability phase in the disc or fatigue failure. You get this reparative phase. This is also associated with pain. So type 1 and type 2 changes of this size are associated with pain. And again, that's been shown in several different studies, and people keep still investigating it, and they have pretty good likelihood ratios. So our implications here for the modic findings is that the type 1 or type 2 lesions have a strong correlation with the disc being painful on stimulation, meaning doing a discography, which is our reference standard. But it's a low sensitivity. So I would say with this finding and with the annular fissure, we cannot use it as a screening test, right? A screening finding. You can't say, oh, because you don't have an annular fissure, or you don't have modic change, that disc is not painful. When you do see those findings within a particular disc, we then improve our specificity, saying that this motion segment is more likely to be the painful motion segment. And for the sake of completion, the type 3, which is harder to see on MRI because it's low signal, is basically dark and dark. And as I mentioned, you can have a spectrum going from 1 to 2 to 3, but you also have mixed patterns. Where here the end plate shows a type 3, where there's dark and dark with sclerosis, and the adjacent end plate below it shows a type 2. So in our population with back pain, and specifically looking more at discogenic pain, we could look at these findings of the HIZ or annular fissure and the modic end plate changes. So now let's talk about the posterior elements. So the facet joint. So the facet joint is a synovial joint, like the knee joint or like the shoulder joint. It has has hyaline cartilage at its articular surface. It has a synovial lining. And so the imaging hallmarks we look for with osteoarthritis is joint space narrowing, but what that really means is hyaline cartilage loss. So when we say joint space narrowing, we have to think about the joint in the loaded condition, and that'll become very critical when we talk about the spine and how we image it. Osteophytes, these marginal osteophytes, and then some kind of subchondral bone reaction, which is often a bone marrow edema, or if you work in rheumatology circles, bone marrow lesions, where these flame-shaped areas of bone marrow show up and can turn into cysts, subchondral cysts, which we're more familiar with. So in order to detect these best, I think it's imperative to have a fluid-sensitive sequence such as a STIR or T2 facet. So in the US, the protocols are very variable, and when I talk to surgeons and to pain management doctors, it's much to my surprise that a fluid-sensitive sequence is not included routinely in their spine imaging. It only takes a few more minutes, but it becomes very important because it improves the conspicuity of seeing these findings. So while we see this edema here that's in the pedicle, you might be concerned that it's a neoplastic lesion because they can go to the pedicle. If you really follow the signal, it becomes confluent with the subarticular part of the facet joint, and there's actually a little bit of capsular edema around the facet joint, the capsulitis, which we would see in other joints. So if we see this in the knee joint or in the acromioclavicular joint, this is related to osteoarthritis. And so in this sense, we're translating what we know about the knee joint, which is established by things such as the Osteoarthritis Initiative, what are the pain markers in knee imaging, into things like the facet. And this has also been done with facet joint injections, although many of the studies that were done have only followed the patients for several months. And so whether you see it on CT, you can see very severe looking facet osteoarthritis. That doesn't tell you it's pain. It's this inflammatory component, whether it's on the STIR or T2 facet type sequences, or if you give gadolinium, you'll see enhancement around it, as you can imagine. So now we get to this facet joint here. So if you look at this facet joint, you say there's some arthritis here, but there's some joint effusion, but where is the joint space narrowing? To me, this is a paradoxically wide joint. So why is this joint wide? Because the person's laying down, right? When do we load our facet joints? So when we're standing up. So this person is unloaded. So looking at this image here, you can say that this segment probably has some instability or hypermobility. And this has been shown with an Italian study and other studies that if you look at those motion segments that have this widened facet joint, and at our place we do a lot of X-rays. We have 50 X-ray rooms. We do 1,000 X-rays a day, and a lot of them are spine X-rays. And we always do them upright loaded. And so it's important to have upright loaded imaging, particularly for the spine, to identify this area of listhesis that may be dynamic or hypermobile. There's different ways to define instability. You can use 3 or 4 millimeter change between flexion extension. But this is the finding that correlates with that MRI. So let's talk about stenosis. So spinal stenosis can cause radiculopathy and neurologic symptoms, but per se it's not a cause of back pain. You get neurogenic claudication. And so back pain can be caused by other lesions that are concomitant with stenosis, such as facet arthropathy. And so our classic stenosis, we get this trefoil type appearance, this Irish icon where you get this narrowing of the typically elliptical thecal sac into the triangular shape, the effacement of the cerebrospinal fluid from the traversing nerve rootlets, and it's typically on some combination of a developmental and acquired cause. So developmental meaning your pedicles are a little bit short, you don't have as much reserve, so when you get these hypertrophic or proliferative findings in facet OA and a little bit of a disc bulge and a little slip, it all comes together to decrease the space inside the central canal. Now we can also have foraminal stenosis from a concomitant things where you get some part of the disc and osteophyte projecting into the neuroforamen, as well as the superior articular process osteophyte there, compromising the foraminal stenosis. And so this is where the sagittal images are very important, looking out, making sure you're looking all the way out from left to right on your sagittal images for these foraminal lesions. So the foramen or canal runs orthogonal to the sagittal section, so it tends to be a little bit better than your axial images for identifying these stenoses. So now with our disc contour abnormalities, we can have a normal disc, think of it as a circle, or we can have a bulge, which is a diffuse abnormality. So let's say greater than 50% of the circumference or greater than half of the perimeter. So that's our bulge. And then we have herniations. So herniations is a focal extension. You can have one that has a broad neck with a small amount of material that's protruding into the canal, known as a protrusion. Or you can have one that has a smaller neck with more of the disc material displaced into the canal. So that's an extrusion. So whether it's based on the AP dimension or the craniocaudal dimension, an extrusion has more material that's displaced into the canal. Pathologically, the outer annulus is disrupted. Now, we cannot always appreciate that on imaging. And then if it loses its connection, this is known as a free or sequestered fragment. So what this means is that when we do our imaging protocols, it's important to have at least one set of images that are parallel to the intervertebral discs, because that's the best way to characterize these contour abnormalities. So that brings us to radicular pain. So now we're talking about pain that's shooting down the leg, a lancinating or shooting pain, and sometimes known as sciatica. It doesn't have to follow one particular nerve. It just basically has to be shooting, typically below the knee. And so when somebody comes in with those symptoms, that's a bit easier or better. I like that better, because usually you can find something, or you should be able to find something that causes that if they have those kinds of sciatica or radicular type pain symptoms. Now, this is different than radiculopathy. Radiculopathy is loss of the nerve function. So the nerve function has a sensory and motor function. So if they're losing sensory and motor function, then the nerve is basically dying or being injured. They may or may not have pain with that radiculopathy. And then again, typically radiculopathy is one nerve root, but radicular pain or sciatic pain is just general pain into the leg below the knee. So again, we look to Christian Fearman and his group at the Balchrist for looking for a grading scheme. We don't use this formally. This is a very good concept. So you want to look at the disc material. Is it not contacting any neural elements? Is it touching or contacting a neural element, meaning it's just touching it but not displacing it or deforming it? Is there this deviation? Is it pushing it away? Now at our shop we use the word impingement a lot. So typically for deviation we will use the word impingement. Or is there some actual compression? Meaning, is the nerve being pushed against another structure? And when we think about a disc herniation, the disc herniation is pushing the nerve typically against the facet joint in that subarticular zone. So that's compression, deviation, and contact. Again, we tend to use the word impingement for deviation, where it's impinging or pushing away. And so this is a nice example of a large extruded disc that's compressing the nerve in somebody with left lower extremity sciatic symptoms. And so it's compressing the traversing S1 nerve there at the lumbosacral junction. In the differential is the synovial cyst. So synovial cysts, as you heard from Dr. Kransdorff, they come from the facet joints and they go into the spinal canal, but they can cause similar symptoms to disc herniations, meaning they can cause irritation along the nerve. These lesions are not simply compressive lesions. There's some inflammatory component. That's why epidural steroids can work well for some of these lesions. Again, if you were to simply compress a nerve over time, you would get a radiculopathy, meaning you'd lose sensation and nerve function. You may or may not have pain, but it's the fact that there's some irritation or inflammation around it that gives the pain component. And so that's a synovial cyst, and it gets to where we talk about specificity. So as I mentioned, in general, for degenerative spine findings, about 1/3 to 2/3 of non-symptomatic patients will have these changes or changes of maturity, as you may want to call them. So these typically increase with age. While annular fissures can be seen with either group, if you're imaging somebody with low back pain, you would implicate that motion segment as more likely being painful. And then things like disc extrusions, severe central canal stenosis, where you lose the cerebral spinal fluid surrounding the traversing nerve rootlets, nerve compression, are more likely to be symptomatic. And of course, you have to put it in the context, so we're looking for concordance of these findings with the patient's symptoms. I'll just finish up with the potential work that we did before I was at Hospital for Special Surgery. I'd worked at Johns Hopkins where we did a lot of MR neurography, and we're doing a lot of that now. We're using some heavily fluid-sensitive sequences to really improve the depiction of nerves here, as you see with all the arrows. Unfortunately, the vessels are still also bright, so you get slow flow in the veins. That can be confusing, so we're looking at vascular suppression sequences to help with that. But in people who have this type of pain, it may be useful as an add-on sequence. So typically we do our stirs as a sagittal image, but doing a 3D stir type sequence may be useful as kind of a neurography add-on. And so here we have a lateral disc compressing the nerve. We see some denervation in the paraspinal muscle there with the feathery edema and the small arrowhead. And then on this coronal reformatted image, we can see the so-called MRI features of radiculitis of that inflamed nerve. So, kind of in summary, MRI has a high prevalence of these non-symptomatic findings. So our job is to categorize the pathoanatomy. Is the way one of my colleagues says that if somebody was to go to autopsy, they should find what I identified MRI. Can I always tell you that's painful? No. So what I've done here is really pull out the types of findings that have been supported by the literature and our experience that are important to mention or to highlight in the impression of the report. And that realize that MRI is done in this non-loaded position, so complementing it with radiography. And thank you very much.